works. Good deal. All right, so I have no disclosures. So, okay, so there's no reason to be nervous. Just yell the answer right out when you have it. There we go. It's one of my favorite angiograms. So we'll start with a real quick, easy one. This is an angio of Glenn. I heard Glenn somewhere. Okay, and then who got it? All right, and then here's a bonus mug question. What? All right. Can anybody tell me what the initial palliation of this patient was? There's a hint in the angio there somewhere. What the initial palliation was. So I was looking. So yeah, there is a stent in the LPA. I was looking for something. So this is obviously a single ventricle that can go one of two pathways for stage 1, Norwood or hybrid. Yes. Do you know why hybrid? You can see the remnants of the PDA stent there. So, yeah, it's there. All right, here's another quick softball. This is the coarctation. Good job. I'll take that mug. Okay. All right. So this clicker is not working. There we go. Okay. So this one was a cool angio we ran across. Anybody have any idea what the last balloon was that we might have used in this intervention? Nobody? Anybody? Bueller? Where's the wire that the arrow is pointing to? It might not be entirely inside that sheath.
So I think they're confused.
Okay.
So why don't you just look at the picture, look at your wire. Asking about the balloon is probably a little bit confusing, but first of all, say what was wrong with the picture. Go back to it. What's wrong with this picture? He even has a blue arrow pointing to the. What's wrong with the wire? Who's saying it?
Somebody said it was outside the sheath, right? Okay. So
How did the wire get outside the sheath?
it's migratory. No. So the last balloon that, I'll move it along here, the last balloon was an 8mm cutting balloon that sliced the sheath on the way back out. So the wire kind of moved outside the sheath there. Do what?
Yes, it was a tough one, but now that you look at it, some of these images that you see, they'll kind of be ingrained and you'll pick up on it. It may not happen for 5 years, but you might remember something like this in the future, so. No, so it was just removal of the cutting balloon. It was we used the cutting balloon, deflated it, removed it, but it sliced, the atherotone sliced the sheath on the way out.
You have to be careful with the cutting balloon. It doesn't always fold back up. If it's on a curve, sometimes you can cut the sheath and you don't even know it. Sometimes when you take sheaths out, that was because the wire was outside.
So it was really flat when you took it off. It was shaped perfect.
Yeah.
And still
Fold it
cut
back
the
in.
sheath.
Yeah, yeah.
All right, so this is a patient population that we don't always get to do a full cath on when they come to the lab. I thought it was an interesting picture. So just based on the ventriculogram, what the anatomy is, or what the congenital disease is. Don't be shy. We're all friends here. Okay, yeah, exactly. Yep. Transposition.
the heavily trabeculated ventricle there.
Yeah. All right, so this was an angiogram that we took that was very cool. This is purely a diagnostic catheterization. And so looking for what anatomical variant we might see here. Yes,
Excellent.
very nice. These are some hard fought for cups here. These are some hard fought for cups here.
Yeah,
So, all right. So this is a 31-year-old Shone's complex patient, status post subclavian flap repair of the CoA, subaortic membrane resection, VSD closure, and dual chamber pacemaker for post-op heart block. And we brought this patient in for a diagnostic cath, and we came across this angiogram. And there's two different slides here, so I can kind of go back and forth once you have your fill of this one. Single coordinate? No, this is actually a selective into the left. So there's a feature of the coronary. Go back here to the first one. So the answer lays somewhere in the leads. How do I get this to play again? There we go. You're looking at me like I'm nuts. Yeah. We took this angiogram. We took it in a couple different planes, and it looks like we had a myocardial bridge. And one of our interventionalists thought maybe it was part of some of those pacing leads crushing down on top of the.
Is that point, I mean, can you point to
Yeah.
that screen up there so they can see it? Ooh. No.
Right there. See how it crushes down there? So it's consistent with the.
Can you guys see it? So, some of these guys probably can't see that screen. Can you guys see where he's talking about?
Yes.
How when the coronary artery narrows down underneath those leads?
I don't have
He's
I got a clicker that I
got a clicker,
clearly
but-
can't operate. No. All right, we'll move on here. There you go. Okay, so this was a cool echo that one of the fellows brought me. This is a patient in the PICU who was actually getting ready to be put on ECMO when they did a real quick echo, and based on this echo, the patient actually went right to the cardiac OR for repair.
So you're looking at the same image, one with color flow Doppler.
Yeah, I think it's more clear on the 2D.
Yeah.
I don't think the color adds a whole lot, but I would look on the left side of this heart. No, the ventricle, they didn't bill it as hypoplast. I think in that angle, you're not quite seeing the left ventricle as big as it really is.
So you're looking at the left side of the heart. Look at above the valve.
Eh? No. See if I can, every time I click on the pointer, right there. I don't know if-
I know a lot of people work in the cath lab, they're not used to looking at echoes,
yeah,
but
that's why I brought this, is because the echo is becoming more a part of our environment. So it's good to. I'm sorry. I didn't. Yeah, not anomalous pulmonary veins. Yes.
excellent.
Oh, I'm sorry. I didn't. I apologize. I couldn't.
You guys
Yes.
need to get up to the microphone. Good job. That was a tough one, you don't see it a lot.
All right. Is that how much time we have left? The 10 minutes? Okay. Okay. I got a couple of cool ones I want to make sure we get to. Okay. So this is an angiogram that we took on a patient who was a combined cath and electrophysiology study. And the electrophysiologist noted having some difficulty advancing a catheter from the femoral vein into the IVC and into the right atrium. I took this picture, and I thought it was important that everybody are able to recognize the injury that occurred here. Again, we're not sure when the injury occurred, but we. No, that's the only one I had. I talked to.
Perforation of the IVC, right about the liver.
Yeah, dissection. Yeah,
Yeah.
that's that lucency line there that you see. It's important that everybody, nurses and techs are able to recognize that, as a complication. I think we're going to skip this one because it's actually double of. All right. I'm going to show your age here if you can tell me what procedure was performed here. Yep, she got it. Yep. Anybody else know what that is? I'd never.
Blade
Blade.
septostomy.
Yep.
Same Park with atrial septostomy.
Yeah.
Same Park was a cardiologist in Pittsburgh, and this was years ago when we didn't have any way to open the tough atrial septum in older patients. This is a blade septostomy that's used as a cutting to cut the thick septum before you do a septostomy procedure. Don't see them very often anymore.
Very, very floppy septum, right? I mean, you had to put it down very, very low, right? It had to be very floppy.
Yeah, you'll see, you push slow. This is the large, this patient, we had to decompress. You can see a cannula in. So we were decompressing the left atrium. And you just pull slowly. And unlike a normal septostomy and a normal transeptal, the blade is leftward on the AP, but it's anterior. You got to cut anterior. If you cut posterior, you'll cut right into the valve. So, and you pull slowly. The surface that's out, the lowest surface, is the cutting surface. And you just gently pull the blade back, and you'll see it go against the septum, and then it pops through. And because this patient, again, had to get the left atrial decompressed. And it was too old. I think it was 11-year-old.
Yeah, he was a big 11-year-old.
It was an older patient, so you can't just go in and do a septostomy. And we didn't want to put a stent because they were going to try to, they'd have to take the stent out then, so. I had to order this. I'm one of the few, if you trained in Houston or Chuck Mullins, the only people that really learned how to use this, unless you're in Pittsburgh years ago. So I got rid of these catheters years ago, just because we have cutting balloons and stuff. But for this specific kind of case,
It's really the safest and best thing. So we now keep one large one in the lab. I got rid of them about 15 years, but we'll keep them in the lab now.
All right, so this is sort of a catheter course question. Based on following the catheter courses, can you determine what the disease is and what the surgical correction? Somebody said it.
What's the catheter course?
So,
Can
yeah.
you give her,
What?
what'd you say?
She said mustard.
Okay.
Yeah. Yeah.
So, and describe the catheter course?
You told me.
Part two. Go ahead, explain, just describe the catheter course.
No. So this is a classic, diagnostic catheter course for these guys. IVC, RA, over to the pulmonary ventricle, and then out the PA, and then you can see your pigtail going up the aorta, but going to your more anterior ventricle. So this is the classic catheter course.
She gets half a month.
Half my. So this one has a couple of slides here. I'll try to get through it. Hopefully it's. So this was again, these are echo images, and I brought some echo images because echo is alive and well in the cath lab, and so the more, us or techs and nurses are able to look at echo and know what's going on, I think it's very important. So this is a patient who originally was a double outlet right with mitral atresia and a hypoplastic LV, had good pulmonary blood flow and status post MPA band, and then had a balloon atrial septostomy 3 months ago. So basically somebody going down a single ventricle pathway with a PA band and balloon atrial septostomy, and presented to the cath lab now with a capillary wedge of around 20 and left atrial pressure around 20. So I'll show a couple of slides here. And the question is what intervention is going to be performed? So this is after the intervention was performed.
You stented the atrial septum. Stenting of the atrial septum.
Yes. Yep. So that's the stent there. After it's been placed in the atrial septum, you can see the flow is wide open. And I just brought a few of the pictures of the stent being deployed because I think it's really kind of cool. And there's the right atrial side. So it's interesting on how we do these. Put the sheath out into the left atrium, pull it back a little bit, expand that left atrial side of the stent, and then bring your sheath further back here and continue to expand it on the right atrial side. All right. Flying through these. Okay. So this is just a still image, but we're looking for what the intervention was performed and where. If you sat and talked to or listened to Dr. Gillespie's talk, you might. Valve and valve, but where? And which valve? And what diameter? And what balloon did we use? And what sheath?
I'm still going to say it's pulmonary.
Pulmonary.
Tricuspid?
A little more posterior than that. I don't know if you can see this, yeah. So you can see the spine there with the spinal fusion rods. So we're all the way posterior.
Gotta get rid of them.
Did you say it? Somebody say it? So mitral. Yep. So that was a valve and a mitral through a. Oh, you did? I'm sorry. Get her a mug.
Give that woman a mug.
Normally, when you look at the AP, you'd say, well, It's not an AP, it's RAO, but you'd say, oh, maybe that's tricuspid. That's actually RAO. That's why you outline the mitral. But the lateral, it's way posterior. So it was a transeptal valve-in-valve for mitral valve.
The lateral gave it away.
Yes. I should have shown that one second. But okay. So this next one is everybody's favorite, hemodynamics. And so there, this is looking for what the abnormal tracing feature of the ventricular curve is. A couple of, this is aorta and I believe the RV on a 100 scale, and then we'll move over here. Here's EDP. And we're looking for the So here's the EKG. Study that for a second, then we can go back and look at the tracing.
Percutaneous closure of a paramembranous VSD in the AV block 3 afterwards.
No
was
and
not.
yes. No closure, but third-degree heart block, which gave us these tracings and the diastolic. So we had a so what I was trying to show here was was in the diastolic tracing of the RV, the contraction against a closed AV valve and third-degree block gave us this really nice spike in the diastolic between the beginning and end diastolic tracing and the ventricular tracing. All right. So this actually goes along really well with Dr. Gillespie's talk a little bit ago. Which previous surgical valve was placed? So knowing angiographically what your valves look like. That is a Hancock indeed. Yes, it's a 16-kilogram tetralogy of Fallot patient with a Hancock valve that we revalved with the Melody valve. So looks like we got a nice result there. All right, so this is an unrepaired DTGA. We had a run of these unrepaired DTGAs that came into the lab for multiple reasons. So unrepaired DTGA with multiple VSDs, and the question we're asking here is where is the tip of that wire? Where did we end up? Multiple VSDs. So a little hint here, we're looking at the PIC line. The PIC line looks like it was inserted in a right brachial position.
There you go. Say it again.
The innominate, yep, exactly. So we're going all the way through the heart, through the VSDs, and out into the innominate there. So that was sort of an accidental wire position, but I made Darren take a picture of it for me. All right. Did you finally get your mug? You're good? Okay.
We're not going to stop till everyone has a mug.
What we didn't tell you is the last couple of mugs actually have drinks in them. So, yeah, but one per customer. I'm sorry. So, okay. All right. So this next one is actually kind of tricky. So this is a 15-year-old AVSD patient, status post-repair, with a mitral valve replacement, and he's now has shortness of breath on exercise. So this is actually not the greatest picture, and I still kind of struggle with it a little bit, but I'll flash up the anatomical markers. So, And this patient actually did come to the lab, so I promise you there's an x-ray in here for you x-ray people. Okay, and again, our anatomical markers. Okay, and then here's our angio that I promised. So you can see the mitral valve in there. So that's a LV gram, and you can see the mitral valve in there, and something else is lighting up. So we're trying to figure out what that.
No idea.
Watch your LV.
So you have does this child have a syndrome?
I don't
It's a
believe
Down
so.
syndrome?
No, it is non-Downs ABSD.
Okay, but it's Gabode defect,
got-
right? Defect of Gabode?
Yes, well, yeah, so Garibaldi-like defect. I don't know, can you still call it Garibaldi after a repair? I don't know if you, so I'm not sure, can you still call it I called it a Garibaldi-like defect.
Yeah,
I don't know
Yes.
after repair if it's still like a Garibaldi defect. Yeah, so what he's talking about here is there's actually a left ventricle to right atrial shunt. And then this still, it actually, I labeled stuff. So you can actually see here from the left ventricle, you can see it going to the right atrium. There's a shunt that's opened up after the mitral valve replacement. We did close it indeed, yep. Yeah. I'm sorry?
Wasn't quite the whole story.
I wasn't,
We did close it, they came to us to close, and we did. The patient came back within a week with coke-colored urine and anemic. And what happened was the device interfered with the valve function, this mechanical valve, and came back, and am I not correct, Sharon? I mean, this is when it came back, yeah.
yeah.
Hemolysis, coke urine, anemia, and because it interfered with one of the leaflets, that's a very common cause of hemolysis in the mechanical valve. So this patient did go back to surgery and had the whole AV septal defect changed and reinsert the valve in it, because they didn't close the defect there, and they still had, I think they had residual, there's another residual somewhere, but they went back for
Yeah,
surgery.
they redid the whole
They
thing.
redid everything.
All right, so this is a patient who was 2 hours old and originally was billed to us as a double outlet right with an intact atrial septum, and they actually came directly to the lab for emergency atrial decompression. And on our first angio, this is our first angio in the plan there. There we go. So we're going to see if anybody can come up with a diagnosis for this patient just based on this one angio.
So if I'm not mistaken, this was the helicopter?
Yeah, this is the helicopter, yeah.
So this was a fetal diagnosis of hypoplastic left heart syndrome with suspected intact septum. And then the baby was born, and this is the angiogram.
So something's missing in this angiogram. And I know it's not the PIC line placed in the right femoral. I'm sorry, no, it's not frozen. I did a bad job of.
So if you do
You
a
can
PA,
stop it.
if you do a PA angiogram like that, watch, there's the pulmonary arteries.
He doesn't have an
Without-
LPA.
Oh, there's no PA, no.
It goes out to both lungs.
There's the left on the left and the right on the right.
Watch the flow to both lungs.
So watch it go out to both lungs. There's the left, there's the right. What are you supposed to see when you inject in the pulmonary artery?
Yep. Pulmonary veins.
There's no
yeah.
Pulmonary
Yeah.
veins.
You don't see the flow coming back from the pulmonary veins.
So I'll read directly from the physician report, but the findings were there was severely obstructed intraparenchymal pulmonary venous return on the right and severely underdeveloped pulmonary veins on the left with mixed drainage to the LA, innominate and diaphragmatic areas there. So, all right. See if you're.
And I was just gonna say, so the fetal diagnosis saw the central pulmonary veins, and they were dilated with reverse flow, and this progressed from the time that fetal echo was done, and then they re-echoed when we saw this, and there were no central pulmonary veins anymore. So this was a progressive pulmonary vein sclerosis that all the way went in, and so this only option was a heart-lung transplant for this baby.
Which you did. Which
Yeah,
was performed.
we listed, this one went on ECMO.
This one went on ECMO, I think, that
We-
afternoon.
Yeah, we tried to, they were stable at this time, and but we had to put on ECMO that first day or two.
Yeah, that afternoon.
And they got listed, but heart lungs are tough to find when you're on ECMO sometimes.
All right, we got the coffee club going over the side of the room, so we need to pick up on the other side of the room.
Joanne, your side of the room is losing. I just wanted to let you know.
Do you want me to give you their names? Little section they did.
Help
All
your,
right.
help your team out over there.
Yeah. All right, so if you were paying attention during an earlier lecture today, Joanne. Anybody else? It is a sheep IVC, yes. TSA is going to find you on the way back to wherever you're from, and they're going to love you. All right, so this was coarctation of the aorta patient, status post-repair at 10 years of age. Now he or she is 55 years of age. And we placed this stent in, which is a covered CP stent, and took this angiogram. And we're looking for the angiographic abnormality.
Extravasation.
Extravasation, exactly, yeah. So this was called a partially contained tear of the superior edge of the stent. And we being, I think, is this Darren? This is Darren's, right? Yeah, we being Darren very calmly and collectively got another covered stent out and fixed this up in I didn't include the other angio, but it actually looked really nice when he was done. So, all right, this is a great one. This is sort of where, oh crap, I gave away the answer. There we go. All right, well, happy on the click button there. So this is a 4.6 kilogram Vactrol patient with pulmonary hypertension, multiple VSDs, status post MPA ban and PDA ligation, and came to the lab for a diagnostic cath. And so we're actually looking for where do all the catheters go. I think the important part here is
By one, which one you wanted the name?
no, I put them all in one.
Just
No, I mean,
Oh.
no, by your.
point.
There you
Oh,
go,
the pointer? Yeah. I
Point
could-
to,
All right,
point and ask.
just start with the easy one.
Start with one of them. Okay.
So that is
Do it on this screen over here, so this side of the room.
this one. Okay.
There we go. Yeah, Kathy, she got it.
Yeah.
Okay. Perfect. Here we go. All right. This is technology right here, baby. All right. So this one should be fairly easy. That is the pick line. Yep. Okay. This next catheter here. Outside the cardiac silhouette. There we go. Okay. Get this one right here. This is, so, yep, that left ventricle. And then this one is slightly trickier. It is indeed. So, there you go. Oh, I didn't do the left atrial catheter, but there we go. All right. Oh, this is a great one, actually. All right, so this was an 8-month-old patient referred for cardiomegaly and a heart murmur. Echo at the time demonstrated severe mitral regurg, dilated left ventricle, and left atrium. with mild to moderate reduction in LV function. We got to the lab and we took this picture. And followed by this selective picture.
Wow. Fistula. Coronary fistula.
Nah. Close. Look where it's going back to.
Or LCA. Oh, sorry. It's the RCA's collaterals are feeding the left coronary arteries.
They are. Can you see where the left coronary artery is originating?
Where's the left corner?
Oh, the origin? Oh, yeah, it's a PA.
Yeah. Yeah. PA. So this is a classic Alcapa.
So
Dr. G.
extra points, name the syndrome. This is for you, Jason. Name the syndrome.
Syndrome.
It's anomalous left coronary artery, correct?
Yeah. I don't think I know that.
White bland Garland syndrome. White bland Garland syndrome.
White Lane Garland.
Gregor knew that.
Okay.
Give him a mug.
That's what John needs is a pig's mug. All right. So this one should be fairly easy for people who are in a cath lab on a regular basis. What was the previous surgical procedure? Typically done on single ventricle palliations. That's a DK. How many mugs do you have over there?
You need to share, Joanne.
Yeah.
Karen has probably shouted out everyone, but we can't hear her voice because she's so sick.
All right, so this was a PDA closure in a 4.7 kilo patient with multiple comorbidities, and it showed this picture, and then the next one here, once you've taken this one in. And then my question is, would you let this go, and if you would not, why not?
Make them go through, name the device, where is it,
Okay,
what
so
do they say in the angiogram, and what they release.
All right.
Switch down when you let go. I just
Say
said it's
again?
really impinging on, out into the PA, on the
On
pulmonary
the PA side there? Yeah,
Yeah.
so originally, you can see here in the angiogram, you can see the measurements we made of the PA, and I think it goes down by about half. So we were obviously very concerned about this in this patient, so we did drop a pressure wire to look at the pressure before the device and after the device, and there was about a 20 millimeter gradient in this device. So. All right. Are we good on time? Are we?
So, yeah, unless you have one more pressing one to show.
No, we can. The rest of these are. Yeah, I think we're
We'll
good.
show one more quick one.
Okay, we will go to, not this one. This one. Okay, so this is just a tracing recognition type question. So if you saw this, this tracing when you came into the lab. This is a 4-year-old NICU baby who was trached and invented. And based on the tracing and knowing that it's a NICU baby, what would be the possible indication for coming for catheter-based treatment in the cath lab? 4-month-old.
So many week preemie.
I didn't write that down. I'm assuming. So this is the picture after intervention. This is the tracing after intervention. This is the tracing before intervention. PDA closure. Yep. Why? So you got in this aortic tracing, you got a lot of diastolic runoff, right? So you've got a really low diastolic, and then after closure, that diastolic shortens up a little bit. So. All right, that's all.